On this episode of the Ask Mike Reinold Show, we talk about biceps tenodesis, we talk about the concept of an annual movement checkup, and we talk about capsular patterns. I remember the last one there. Capsular patterns. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I'm up here at Champion PT and Performance up in Boston, Massachusetts. Dave Tilley is here, everybody. Dave Tilley is here. Hello. Lenny Macrina, Dan Pope, Mike Scaduto, everybody at Champion's here. Our student, so many big plays. There's so many good things we can say about our students right now. Tons of students. I love how we have 3 asking 1 question each. That's kind of cool.
I like it too.
Pretty good. But
divide and conquer.
Let's see. We have Travis, 2-Step from University of Kentucky. Matt M.K. Kelly from Dalhousie University in Nova Scotia. We have yet to come up with a good nickname for Matt. And Lexi Malone, because she needs no nickname, from Simmons College in Boston.
Nailed it.
Nailed it. Awesome. Take it away, 2-Step.
Renee from Mississippi. Shoulder question. Do you recommend surgical repair for a proximal tear of the long head of the biceps tendon, specifically in an active individual who does CrossFit?
All right, so shoulder pain, it sounds like an MRI shows you have some tearing of the long head of your bicep. I'm going to assume that's what you meant when you said proximal bicep. Dan, in your experience, how well do these rehab somebody that actually probably has some tearing of that biceps, that long head?
Well, I guess probably the Tenodesis is what we're thinking about, right?
I would assume that's the surgery they're talking about with her.
Yeah.
So 2 questions for you is how often do you see that? How often do you see rehab working for that? And then what do you think about a tenodesis and getting back to CrossFit?
Yeah, so I have a surgeon who used to like a lot. His name's Armando Vidal up in Colorado and Denver. And he actually did a bunch of research on tenodesis, and he sees a ton of CrossFit people. He was a guy I referred to a lot. And he tells his patients when they have a tear there or they feel like they need to snip it, that the outcomes are pretty similar, which I think is evidence-based. I think the tenodesis versus just cutting the tenotomy have pretty similar outcomes, and maybe Lenny can speak to that a little bit more. But generally, I would see people with a tenodesis, and to be honest, it's a harder rehab because you're dealing with everything that goes with a surgery, you know. A lot of times people get like a rotator cuff repair plus a tenodesis. I think the major thing that Vidal talked about is that it's cosmetic. So if you just cut that thing, it's not going to look the same. So he would just ask the athlete, like, do you want to get this repaired? Do you not? The outcomes can be pretty similar in the long run. And he treats a lot of people that are like CrossFit Games athletes too. So I feel like it does span the spectrum of normal people up to high level. So
yeah, and I would say, I mean, it's one of those things where it's being performed because you have so much shoulder pain. If you just get rid of that source of shoulder pain, it does tend to help with symptoms. The question is going to be long term.
Yeah.
You know, and I don't know if we know the answer yet, but you know, Dr. James Andrews down in Pensacola, Florida now. I mean, he always says like it was there for a reason. You know, so I don't know why we'd necessarily cut it out. I mean, he still prefers not to cut it out. So I don't know. I mean, has anybody had any experience with tenodesis not doing well and getting back to CrossFit or anything? Like,
I don't have
or
any
even Olympic
CrossFit.
lifts?
I mean, I have 3. I had 1 in my previous facility that was more Olympic weightlifting, and then I've had a gymnast, and I have a non-athletic, just kind of general person. And I think that it's tricky to get back to higher level stuff because of how long it takes and how impatient I think sometimes everybody is. Like, to get back to that level of activity, it's just like CrossFit is extremely shoulder intensive, and I think that the grunt work you need, the amount of patience you need, the planning, the programming, the periodization, the checking your ego at the door. Maybe you're not going to get back to heavier snatching or all that stuff for a long time, if not at all. And I think that's hard for people sometimes to do. If they're a competitive athlete, it's you kind of write your name on the dotted line that you accept some of that risk. And I think that it really depends on what their goals are. That's a dodgy way to do it.
I kind of wonder, I mean, like, what's the chances that magically the long head of your bicep is the only thing that's wrong with you?
Yeah, exactly.
So we just cut it and it fixes it. Right? I mean, there's probably reasons why that happened, and some of those reasons could be, you know, periodization. It could be programming. It could be coaching. It's not only just, you know, it could be just what you choose to do with yourself.
The biomechanical effects of the joint. Does it, you know, depress the humeral head a little? You're now going to get maybe a millimeter more of superior migration, which is now going to put your cuff at risk when you're in a snatch type position or something where you're overhead, heavy weights, and you don't have that dynamic stability. I don't know.
I think we don't know enough about CrossFit yet to know patterns of adaptations, why they have shoulder issues. We're learning, but I don't think we know enough yet.
Well, I mean, I wouldn't even say that's a CrossFit. That was just repetitive overhead activity.
Yeah.
We know in baseball they don't do well trying to get back to throwing a baseball.
Any repetitive overhead activity that you add speed and range of motion and excessive load and volume. I mean, you kind of summarize it, right? I mean, anytime you do that, obviously you're going to get pathology of your shoulder. You know, I don't know if just cutting your biceps is the complete answer, but I don't know. If it was my body, I would prefer to not do that, and I would take a really good hard look at what I'm doing to create that. And I think I'd rather live life with my biceps tendon than without. You know, but
Free the biceps.
free the biceps. So awesome, Matt Kelly. What do we got? Okay.
Eric from St. Louis says other medical professions such as dentists and physicians include annual checkups for their patients. What are your thoughts for the profession of physical therapy to begin including routine movement examinations in order to identify any potential faulty movement patterns that may lead to injury in the future? I think the biggest roadblock is the reimbursement by insurance companies, but if as a profession we can demonstrate the effectiveness of prophylactic care, it may be a large area of growth for our field.
Yeah, I feel like we've talked about this on the podcast a little bit too, but the concept of annual checkups for movement, right? Like to try to enhance yourself here. And man, you layered in a bunch of good questions, I think, within that a little bit. Dentists and doctors have done a good job, I think, because two reasons really. One is I think they've shown that being proactive has results to save money down the road, and that's an insurance company thing in terms of where they reimburse it, but it'll help you health-wise and save some money down the road. I think that's why they've done it, but I also think it's marketing, right? I just think the American Dental Association marketed this better in the 70s or the 80s or whatever it is that they decided to make us go twice a year. You know what I mean? Like that's, to me, that was more marketing than anything else. So they've done a good job. So for PT, do we think we should use it? Yeah, and I mean, to an extent, we kind of do it all the time. But you know, again, maybe it's the image of PT and insurance and stuff that's like really like bothering me here. I mean, insurance is something you do, like it's like a backup in case something bad goes wrong, right? If you think insurance should necessarily cover that, then you know, I don't know. I guess I'm not mad that insurance doesn't cover that, right? Like,
yeah,
I mean,
you get gas in your car, you get new tires. You're not using your car insurance for that. That's upkeep.
You're
Maintenance.
Yeah, it's upkeep for your body, so that way you feel better, you move better, you have a happier life and stuff like that. Like, I think we as a profession need to do a better job at showing the value of that and saying that is, you know, helpful. So anyway, sorry.
No, I think that was well put.
Yeah, we get a lot of that. We get a lot of our clients are people that feel good but just want to feel better, maybe. So they see a value.
Yeah, I mean, so I would encourage you to do it. I would encourage you to start that, but it's going to be a long road.
Education for the patient is the most important thing.
I think we need to do that at a higher level. I think the APTA needs to do that more for physical therapists. So, call to action is we need to start doing that stuff. Let's talk about that at the next conference or whatever APTA conferences they do. But like, how do we actually? To me, this is marketing that it's worth your while to do that. There's a value to do that. You know, I mean, I don't know. I don't know. I mean, if you feel like poop, that's not living life.
Yeah, I think you're exactly right. Yeah. If you work in a specific niche, I think that's way easier because someone like me for CrossFit, we can optimize a lot of things about them. But I was just reading an article in BJSM is if you walk for, I think it's like 150 minutes per week, it extends your life by like 3 to 5 years. So we know that strength directly correlates to mortality. If we're going to be the mortality experts, we're going to be the movement experts.
Whoa, what kind of stuff is Dan working?
We have the death experts and mortality experts. I mean, we have a tremendous opportunity to impact people's lives by changing their behavior and making them move a little bit more. I mean, there's no reason. I mean, flossing your teeth obviously is probably going to help you live a little bit longer too, I guess. But the same thing is that we're going to help people and we're going to have a tremendous impact. And whether that's a doctor that does or whether that's us, is maybe something the APTA has to sort out and fight for us in some ways. We have to fight for that as well. So.
Yeah, totally agree. Lex, what do we got?
All right, Robin from Zurich. Do you ever take capsular pattern into consideration when testing the joint? I hear from some people that this is outdated and not used anymore, and others use it all the time.
Capsular pattern. So I'm going to indirectly answer this question. Let's use the shoulder for example. I'm going to indirectly answer this question by asking, what is the capsular pattern of the shoulder? Which tells you that I don't follow it. It's
ER, abduction, IR.
ER, abduction, IR. So let's talk about
Just studied that.
Right. So I was going to say they're still teaching you capsular pattern?
In the review book, it wasn't a big part of the curriculum.
So they're saying if the capsule gets tight, you're going to lose ER first, most more than abduction, more than internal rotation. How many?
We don't care about flexion.
I would say it's elevation.
Yeah,
Yes.
it's so weird. Yes, we'll call it elevation.
Yeah.
How many times do you see that? What do you think? You see that, Len?
I don't know.
Frozen shoulder.
I don't think I ever see it.
Frozen shoulder is
Yeah.
acute frozen shoulder, but there's a lot of stuff going on.
So,
Yeah.
Usually, so the shoulder is a good example because it's a ball and socket. It's like a circle. It's a little bit easier to, or it has less bony influence, so it's a little bit pure for this discussion, I guess, right? Like, one of the main concepts of shoulder stability is the circle concept. So meaning, if you have tightness anywhere in your capsule, it's gonna, the whole circle gets tight, right? You know, so you're gonna have issues with that. But I don't know if I don't see ER first.
I think we try to simplify things just to simplify it in our heads, but I don't know if it's necessarily textbook for everybody.
If a certain aspect of your capsule gets tight, maybe ER is there. So, I mean, there's different types of stiff shoulders. There's a post-operative stiff shoulder, there's adhesive capsulitis. Let's just chunk it into those two right now. I mean, adhesive capsulitis, you're probably, again, it could probably be anywhere, but it's probably losing the entire redundancy of the inferior capsule, like one whole like main kind of portion in there. But a post-operatively tight capsule, I mean, if you have an anterior bank arc and you tighten that up, then it's going to be what's specific to that tightness. So I don't know. I mean, do you ever see external rotation number one?
Well, I mean, when I was a new grad, I had a hard time differentiating between like, oh, what's a cuff tear versus someone who has potentially is developing adhesive capsulitis. I think it is kind of useful just external rotation, overhead motion would be a little limited. The other part is we saw a bunch of frozen shoulders and it was all different. Like some people were more limited in external rotation, some people a little more flexion. But if I'm seeing someone who's really, really limited in external rotation, have a painful shoulder in general, and everything kind of hurts, all the special tests are positive, I would start to go down that pathway. You know, to say, hey, maybe with a doctor, cortisone shot, more physical therapy, it looks like you have a frozen shoulder. Whereas someone else, I would be like, oh, it looks more like you have some cuff irritation, impingement. Let's just treat this more conservatively. I don't think you need to go back to the doctor.
You'll look at the capsule. You look to see if the capsule is tight. So I mean,
but then I think, why do we care?
That's a good question too.
Are we doing joint moves to try to stretch out the capsule? Because we're probably not. Maybe it's neuromodulation of pain, but yeah, we want to assess the capsule. Maybe we can feel if the capsule's tight in a certain range. Maybe that'll help us, but I think it's just all about regaining the motion any way we can. So I don't know if you're trying to go down a road of, I know they have an external rotation deficit, they must have anterior capsular tightness, I need to mold the anterior capsule. I don't know if it's that easy.
Well, can you have capsular tightness and have a loss of IR only?
Right.
Of course, right?
Yeah.
Like I would imagine you could,
right?
I mean, you could lose IR. It doesn't have to be ER more. So I think we're getting a little like talking about like just capsules getting tight and stuff, which is fine. But like the capsular pattern concept, I'm pretty sure that's been disproven. I actually think there's a study. I should know this. I think this is in my shoulderseminar.com program. But there's a study that shows like half the people lose ER first and half the people lose IR first, you know, like, so I just think it's different. So I think we're worrying too much about stuff like that. I don't think we need to worry about that. Just assess and treat based on your assessments and don't worry about a pattern, right? Good? Awesome. Thank you guys, appreciate it. Another good group of questions. You guys are the best. Head to MikeReinold.com, click on that podcast link and fill out that form to ask us some questions. And when you get a second, please, if you're listening to this podcast, go to iTunes and rate and review us. That really helps us. And we'll see you guys next time. Thanks.